Hello, and welcome to another chapter of Pediatric Primary Care. Today we'll talk about Chapter 19, Immunizations. Before we start Chapter 19, Immunizations, please note these are words written in a book, not personal belief. If you wish to follow the book as a guideline, you are more than welcome to. If you wish to use outside sources to dispute, you are more than welcome to. The principles of vaccination. Immunizations have been the number one public health achievement of the 20th century. Vaccines are a critical element of pediatric primary care and have saved the lives of countless children through the prevention of vaccine-preventable diseases. Vaccines are cost-effective public health interventions and are an efficient investment in the health of children and families throughout the world. The immunization schedule is updated annually by the Advisory Committee on Immunization Practices and then approved and published by the Center for Disease Control and Prevention. As data becomes available, the CDC updates immunization recommendations outside of the annual immunization schedule. Primary care providers need to be cognizant of the vaccine schedule and any subsequent changes annually. The most current schedules are published by the CDC on their website. Immunity is the ability of the human body to tolerate the presence of material native to the body and to eliminate foreign substances. Since most organisms are identified as foreign, the ability to identify and eliminate these substances provide protection from the infectious diseases. Immunity is generally specific to a single organism or a group of closely related organisms. The immune system develops a defense against antigens, which are substances that can stimulate the immune system. This defense is known as the immune response and usually involves the production of protein molecules by B lymphocytes and specific cells, including the T lymphocytes. Passive immunity. Passive immunity is produced by the transfer of antibodies or antitoxins from one animal or human to another. Passive immunity provides immediate protection against infection, but that protection is temporary. The most common form of passive immunity is that which an infant receives from the mother. Maternal antibodies provide better protection from some diseases, such as measles, rubella, and tetanus, than from others, such as polio and pertussis. Passive immunity can also be acquired through the transfusion of blood products. Some blood products, washed or reconstituted red blood cells, contain a relatively small amount of antibody, while some, via IV immune globulin and plasma products, may contain a large amount. There are three other major sources of antibodies used in the human medicine, in addition to blood products used for transfusions. These are homologous pooled human antibodies, homologous human hyperimmune globulin, and finally the heterologous hyperimmune serum. Homologous human hyperimmune globulins are antibody products that contain high titers of antibodies targeting more specific antigens. Hyperimmune globulins are used for post-exposure prophylaxis for several diseases, which include hepatitis B, rabies, tetanus, and varicella. Heterologous hyperimmune serum, also known as antitoxin, is produced in animals, usually horses, and contains antibodies against only one antigen. In the United States, antitoxins are available for the treatment of botulism, as well as diphtheria. Immune globulin products from human sources are primarily polyclonal. They contain many kinds of antibodies. Monoclonal antibodies products have many applications, which include the diagnosis of certain types of cancers, which include colorectal, prostate, ovarian, and breast. The treatment of cancer via B-cell chronic lymphocytic leukemia, as well as non-Hodgkin's lymphoma. Prevention of transplant rejection, as well as treatment of autoimmune disorders and infectious diseases, which would include our Crohn's disease and rheumatoid arthritis. A monoclonal antibody product, palivizumab, or Synagis, is available for the prevention of respiratory syncytial virus infections, or RSV. Since Synagis only contains RSV antibodies, it will not interfere with the response to a live vaccine. Active immunity. Active immunity is produced by a person's own immune system. The immune system is stimulated by an antigen to produce antibody-mediated and cell-mediated immunity. Unlike passive immunity, which is temporary, active immunity usually lasts for many years, often for a lifetime. One way to acquire active immunity is to survive infection with the disease-causing form of the organism. In general, once persons recover from the infectious disease, they will have a lifelong immunity to that disease. There are some exceptions, which would include malaria and COVID-19. The persistence of protection for many years after the infection is known as immunologic memory. Following exposure of the immune system to an antigen, certain memory B cells continue to circulate in the blood and reside in the bone marrow for many years. Upon re-exposure to that antigen, these memory cells begin to replicate and produce antibodies rapidly to reestablish protection. Vaccination also produces active immunity. Vaccines contain antigens that stimulate the immune system to produce an immune response. This is often similar to that produced by the natural infection. With vaccination, however, the recipient is not subjected to the disease and its potential complications. Many factors may influence the immune response to vaccinations, which include the presence of maternal antibodies, the nature and dose of the antigen, the route of administration, and the presence of the adjuvant. Host factors such as age, nutrition, genetics, and coexisting disease may also affect the immune response. The more similar a vaccine is to the disease-causing form of the organism, the better the immune response to the vaccine. So, classifications of vaccines. Live attenuated vaccines. To produce an immune response, live attenuated vaccines must replicate in the vaccinated person. A relatively small dose of administered virus or bacteria replicates in the body and creates enough of the organism to stimulate an immune response. Although live attenuated vaccines replicate, they usually do not cause disease such as that caused by the wild form of the organism. When a live attenuated vaccine does cause disease, it is usually much milder than the natural disease and is considered an adverse reaction to the vaccine. The immune response to a live attenuated vaccine is virtually identical to that produced by a natural infection because the immune system does not differentiate between an infection with a weakened vaccine virus and an infection with a wild virus. Injected live attenuated vaccines produce immunity in most recipients with a single dose. However, a small percentage of recipients do not respond to the first dose of an injected live attenuated vaccine, which would include the measles, the mumps, and the rubella. And a second dose is usually recommended to provide an extremely high level of immunity in the population. Orally administered live attenuated vaccines require more than one dose to produce immunity. A live attenuated vaccine may cause several or fatal infection as a result of uncontrolled replication of the vaccine virus or bacteria. However, this only occurs in persons who have a weakened immune system, such as those who suffer from leukemia are getting treatment with certain drugs, or are HIV positive. A live attenuated vaccine virus could theoretically revert to its original pathogenic form. This is known to happen only with the live polio vaccine, which is no longer available in the US. Active immunity from a live attenuated vaccine may not develop because of interference with the vaccine virus by circulating antibodies. Antibodies from any source can interfere with the replication of the vaccine organism and lead to poor response or no response to the vaccine. This is also known as vaccine failure. Live attenuated vaccines are fragile and can be damaged or destroyed by heat and light. They must be stored and handled carefully. The live attenuated viral vaccines currently available and routinely recommended in the United States include MMR, varicella, rotavirus, and influenza. Other non-routinely recommended live vaccines include the adenovirus vaccine, typhoid vaccine, and Bacillus calmette-guerin, or BCG. BCG is not used as a vaccine in the US, but as a treatment for bladder cancer. Inactivated vaccines. Inactivated vaccines are not live and therefore cannot replicate. These vaccines cannot cause disease, even in an immunodeficient person. Inactivated antigens are less affected by circulating antibodies than live antigens, so they may be given when an antibody is present in the blood. The immunity provided by inactivated vaccine is generally not as long-lasting as that obtained from a live attenuated vaccine. Multiple doses over time are needed to obtain ongoing immunity. In general, the first dose does not produce protective immunity, but it primes the immune system. A protective immune response develops after the second or even third dose. Some inactivated vaccines may require periodic supplemental doses to increase or boost the antibody titers. Inactivated vaccines include whole cell inactivated vaccines, such as polio, hepatitis A, and the rabies vaccine. Subunit vaccines, such as influenza and pneumococcal vaccines. Toxoids, such as diphtheria and tetanus toxoids. And recombinant vaccines, such as hepatitis B, HPV, influenza, and mRNA vaccines, both the Moderna and Pfizer brands. Whole cell inactivated viral vaccines against polio, hepatitis A, and rabies are available in the US. Subunit vaccines contain a portion of a bacteria or virus. The portion of the organism selected is the part needed to produce a protective immune response. Antigens in subunit vaccines can be proteins, polysaccharides, or a combination of polysaccharide and protein molecules. Conjugate subunits vaccines, such as the Haemophilus influenza type B and pneumococcal conjugate vaccines, are produced by chemically attaching a polysaccharide from the surface of bacteria to a protein molecule through a process called conjugation. T-cell independent antigens include polysaccharide vaccines are not consistently immunogenic in children younger than the age of 2, probably because of the immaturity of their immune system. Toxoid vaccines are made using inactivated toxins produced by bacteria. These protein-based toxins are inactivated using heat, chemicals, or other methods. Some bacteria cause disease by producing toxins. The ability of the immune system to recognize and eliminate these toxins provide protection from the disease. Recombinant vaccines are produced by recombinant DNA technology. Hepatitis B, HPV, and influenza vaccines are produced by the insertion of a segment of a respective viral gene into the gene of a yeast cell or virus. Serogroup B meningococcal vaccines are proteins and outer membrane vesicles generated by recombinant technology. DNA or RNA-based vaccines are made without the introduction of an antigen. Only the RNA or DNA containing the genetic information is used by the body to produce the antigen. The DNA or RNA is then absorbed by the body and disappears. The vaccine induces cells to take up the mRNA and make the spike protein, and, hopefully, stimulates an immune response. For this specific class of vaccines, the introduction of DNA and RNA provides the instructions to the body to produce the antigen itself. So, general best practice guidance for immunization, timing and spacing of vaccines. Timing and spacing of vaccine doses are two of the most important considerations for the appropriate use of vaccines. Specific circumstances commonly encountered in immunization practice are the intervals between doses of the same vaccine, simultaneous or non-simultaneous administration of different vaccines, and the intervals between antibodies containing blood products and live attenuated vaccines, particularly that of measles and varicella containing vaccines. So, the interval between doses of the same vaccine. Most vaccines in the immunization schedule require 2 or more doses for the development of an adequate and persistent antibody response. Studies have demonstrated that following the recommended ages and intervals between doses of the same antigens provides optimal protection. In general, decreasing the interval between doses in a multiple dose vaccine series may interfere with antibody response and protection. For routine vaccination, vaccine doses should not be administered earlier than the minimum age or at less than the minimum intervals. However, exceptions may occasionally be necessary. One exception involves administration or administering a dose up to 4 days before the minimum age or interval to avoid missing an opportunity to vaccinate. However, if the provider has confidence that the patient will return for a later visit, it is preferable to reschedule vaccination on or after the recommended minimum age or interval. If the patient is new to the provider or habitually misses appointments, it may be preferable to administer vaccines early. These early doses administered within 4 days of the minimum age or interval are considered valid. In certain situations, state or local requirements might mandate doses of selected vaccines be administered on or after specific ages, superseding the 4-day grace period. Doses administered 5 days or more before the minimum age or interval should not be counted as valid and should be repeated as age appropriate. Other exceptions are administering doses in a vaccine series at shorter intervals than recommended when a person is behind schedule and needs to be brought up to date quickly or when international travel is pending. In these cases, an accelerated schedule using the minimum age or minimum interval criteria may be used. In some cases, a scheduled dose of vaccine may be administered late. A late dose should be administered at the next visit. Available data indicate intervals between doses that are longer than those routinely recommended do not affect seroconversion rates or titers when the schedule is completed. Therefore, it is not necessary to restart a series or add doses of any vaccine because of an extended interval between doses. Simultaneous and non-simultaneous vaccine administration. Starting off with simultaneous administration of different vaccines. Simultaneous administration of all recommended vaccines is important because it increases the probability of an individual will be fully vaccinated at the appropriate age. It is also important part of immunization practice when a PCP is uncertain that a patient will return for additional doses of vaccine. In general, almost all vaccines can be administered at the same visit. Exceptions to this include, however, the pneumococcal conjugate vaccine 13 and the MenACWY-T or Menectra vaccine should not be administered simultaneously to persons with a functional or anatomic asplenic or HIV. Menactra brand meningococcal conjugate vaccine is thought to interfere with the antibody response to Prevnar 13. When both Prevnar 13 and Menactra are indicated, Prevnar 13 should be administered first, followed by Menactra at least 4 weeks later. PCV13 or Prevnar 13 vaccine and the pneumococcal polysaccharide vaccine should not be administered at the same visit. Studies show a better immune response to Prevnar 13 is administered before the Pneumovax 23. When both Prevnar 13 and Pneumovax 23 are indicated, Prevnar 13 should be administered first, and the Pneumovax 23 should be administered at least 8 weeks later, or at least 1 year later, depending on the age and health condition of the vaccine recipient. Combination vaccines are generally preferred over the simultaneous administration of a single component vaccine. Combination vaccines contain components that can be divided into independently available routine vaccines and can reduce the number of injections needed. Considerations for using combination vaccines should include an assessment of the number of injections, availability of the vaccine, the likelihood of improved vaccination coverage, the likelihood of patient return, and issues regarding storage and cost. Consideration should also include patient choice and the potential for adverse events. Non-simultaneous administration of live vaccines. If any combination of live injected vaccines such as MMR2, Proquad or Verifax, or live attenuated influenza vaccine is not administered simultaneously, the vaccine doses should be separated by at least 4 weeks. This interval is intended to reduce or eliminate interference from the vaccine administered first with the vaccine administered later. If any two of these vaccines are administered at an interval less than 4 weeks, then the vaccine administered second should be repeated in 4 weeks, or serologic testing should be performed following an MMR2 and Proquad to confirm their effectiveness. Live vaccine administered by the oral route, such as the rotavirus, are not to believe to interfere with parental or intranasal live vaccines or with each other. Therefore, they may be administered simultaneously with or at any time, before or after other live vaccines. Vaccines and antibody-containing products. Antibodies in the form of immune globulin might be administered simultaneously with or around the same time as certain vaccines. Examples of these are as post-exposure prophylaxis for certain diseases, which would include hepatitis B, rabies, and tetanus. Immune response to some live attenuated vaccines can be affected by receipt of immune globulin. Depending on the type of vaccine, amount of antibody, and timing of administration, immune response to inactivated vaccines is generally not affected by antibody-containing products. Inactivated vaccines can be administered before, after, or at the same time as the antibody product. The vaccine antigen should be administered at a site distant from where the immune globulin was injected, which will be discussed further in Chapter 35 under infectious diseases for immunoglobulin administration in children. Live attenuated injectable vaccines. Live attenuated vaccines must replicate to produce an immune response. Antibodies against injected live vaccine antigens may interfere with replication. If MMR varicella, or a combination of measles, mumps, rubella, and varicella. Vaccines must be administered around the same time as an antibody. The two must be separated by enough time to prevent the antibody from interfering with viral replication. If these live vaccines are administered first, it is necessary to wait at least 2 weeks before administering the antibody. If the interval between the vaccine and the antibody is less than 2 weeks, the recipient should be tested for immunity, or the vaccine dose should be repeated. If the antibody is administered first, it is necessary to wait until the antibody has waned before administering the vaccine. This will reduce the chance of interfering with the antibody. An exception to the waiting period for an antibody to wane before vaccination is a low dose of RhoGAM, or Rofelac, or any other blood product administered to women who do not have the evidence of immunity to rubella or varicella during the last trimester of pregnancy or during delivery. Although passively acquired antibodies can interfere with the response to the rubella vaccine, the low dose of anti-Rho globulin has not been demonstrated to reduce the response to the rubella vaccine. These women should receive MMR2, Varivax, or Proquad, as indicated immediately after delivery, and, if possible, to be tested 3 or more months later to ensure immunity to rubella and, if necessary, to measles. Live attenuated oral and intranasal vaccines. The rotavirus vaccine and RV5 and DLA4 are not known to be affected by the administration of immune globulin or blood products. They may be administered simultaneously with blood products or separated from them by any interval. So, its doses. Many factors influence the number of doses recommended in the vaccine series, including the type of vaccine, epidemiology of the disease, and host factors. For live injected vaccines, the first dose administered at the recommended age usually provides protection. An additional dose is administered to provide another opportunity for vaccine response in the small proportion of recipients who do not respond to the first dose. The second dose is administered to ensure that nearly 100% of persons are immune. Immunity following live vaccines is long-lasting, and booster doses are usually not necessary. For inactivated vaccines, the first dose administered at the recommended age usually does not provide protection. A protective immune response may not develop until after dose 2 or even 3. For inactivated vaccines, antibody titers may decrease below protective levels after a few years. This phenomenon is most notable with the pertussis vaccine. Tetanus and diphtheria vaccine-induced immunity also begin to wane. For these vaccines, a booster dose is administered to raise antibodies back to protective levels. Not all inactivated vaccines require boosting throughout the lifetime. An example of which is additional doses of the HIV vaccine is not required after completion of the infant primary series and booster dose because HIV disease is rare in persons older than the age of 5. The hepatitis B vaccine does not require boosting in immunocompetent persons because the immunologic memory of the vaccine and the long incubation period from hepatitis B. Immunologic memory produces an autoboost, which means exposure to the virus causes the established immune memory to respond faster than the virus can cause disease. So, the adverse reactions following vaccines or vaccination. An adverse reaction or side effect is an untoward effect caused by a vaccine. An adverse reaction is different from a vaccine adverse event. A vaccine adverse event refers to any medical event that occurs following the vaccination. An adverse event could be a true adverse reaction or a coincidental event, with further investigation needed to distinguish between them. Healthcare providers are required by law to report certain adverse events after vaccination. Allergic reactions may be caused by the vaccine antigen itself, or some other vaccine component, such as cell culture material or a stabilizer, preservative, or antibiotic used to inhibit bacterial growth. Severe allergic reactions may be life-threatening but fortunately are very rare. The risk of an allergic reaction can be decreased by effective screening before vaccination. All providers who administer vaccines must have an emergency protocol, supplies, and treating to treat anaphylaxis. Local adverse reactions are the most common adverse reaction following vaccination. They generally occur within a few hours of an injection and are usually mild and self-limited. Local reactions may occur with up to 80% of vaccine doses, depending on the type of vaccine. On rare occasions, local reactions can be severe. These reactions, referred to as Arthus reactions, are most frequently seen with diphtheria and tetanus toxoids. Systemic adverse reactions may occur following a vaccination. Adverse reactions such as a fever or rash following live attenuated vaccines may be similar to a mild form of the natural disease, with symptoms produced from viral replication. Systemic adverse reactions are usually mild and occur 3 through 21 days after the vaccine is administered. Systemic adverse reactions from live attenuated vaccines are seen at longer intervals following vaccine administration because they are caused by the replication of the vaccine virus in the body, which occurs over several days. Contraindications and precautions, therefore, to vaccination. Contraindications and precautions to vaccination generally dictate circumstances when vaccines should not be administered. Some contraindications and precautions are temporary, and the vaccine can be administered later. So, listing some contraindications. A contraindication is a health condition in the recipient that increases the likelihood of a serious adverse reaction to a vaccine. In general, vaccines should not be administered when a contraindication is present. A severe allergic reaction to a vaccine component is a contraindication to any vaccine containing that component, and a severe allergy following a dose of vaccine is a contraindication to subsequent doses of that vaccine. The use of aerosolized steroids, such as an inhaler for asthma, is not contraindicated to vaccination, nor are alternate day, rapidly tapering, and short, high-dose steroid schedules, topical formulations, and physiologic replacement steroid dose schedules. Precautions. A precaution is a health condition in which the recipient that might increase the chance or severity of a serious adverse reaction might compromise the ability of the vaccine to produce immunity, or might cause diagnostic confusion. Injury could result, but the chance of this happening is less than with a contraindication. In general, vaccines should be deferred when the precaution is present. However, situations may arise when the benefit of the protection from the vaccine outweighs the risk of an adverse reaction, and a provider may decide to administer the vaccine. Moderate or severe acute illness, with or without fever, is a precaution for all vaccines, with few exceptions. Family medical history is not a contraindication or precaution to vaccines. Contraindications and precautions in persons with a specific health condition. The history of allergic reactions. A severe allergic reaction, such as anaphylaxis following a dose of vaccine, is contraindication for a subsequent dose of that vaccine and is a medical emergency. Anaphylaxis involves two or more organ systems, dermatologic, cardiovascular, respiratory, and/or gastrointestinal. Simultaneously, symptoms and signs of anaphylactic reaction include generalized urticaria, swelling of the mouth and throat, difficulty breathing, wheezing, hypotension, or shock. Anaphylaxis after vaccination occurs rarely and can often be prevented by appropriate screening. Persons may be allergic to a vaccine antigen or to the vaccine component, such as an animal protein, antibiotic, preservative, or stabilizer. The most common animal protein allergen is egg protein, found in influenza vaccines prepared using embryonated chicken eggs. Asking persons whether they can eat eggs without adverse effects is a reasonable way to screen for those who might be at risk if they receive egg-containing influenza vaccines. A person with a history of egg allergy, who have experienced only hives after exposure to eggs, should receive the influenza vaccine. Influenza vaccines may also be administered to persons who report having had reactions to eggs involving symptoms other than hives, which would include swelling of the throat and mouth, difficulty breathing, lightheadedness, or recurrent emesis, or who required epinephrine or another emergency medical intervention. If egg-containing influenza vaccine is administered to persons who report having had reactions to eggs involving symptoms other than hives, it should be administered in an inpatient or outpatient medical setting and supervised by a healthcare provider, able to recognize and manage severe allergic conditions. A previous severe allergic reaction to the influenza vaccine, regardless of the component suspected of being responsible for the reaction, is a contraindication to the future receipt of the vaccine. Studies show that children who have a history of severe allergy to eggs rarely have reactions to the MMR2 and MMRV vaccine. This is probably because measles and mumps vaccine viruses are both grown in chicken embryo fibroblasts, not actually in eggs. It appears gelatin, not egg, might be the cause of allergic reaction to MMR2. Children with egg allergies may be vaccinated with MMR2 or Proquad without prior skin testing. Certain vaccines contain trace amounts of neomycin. Persons who have experienced an anaphylactic reaction to neomycin should not receive these vaccines. Most often, neomycin allergy presents as contact dermatitis, a manifestation of a delayed type immune response rather than anaphylaxis. A history of delayed type reaction is not a contraindication for the administration of neomycin-containing vaccines. Latex, which is a sap from the commercial rubber tree, contains naturally occurring impurities, which are believed to be responsible for allergic reactions. The most common type of latex sensitivity is contact type allergy, usually resulting from prolonged contact with latex-containing gloves. Latex-related allergies reactions after vaccination are rare. If a person reports a severe allergic reaction to latex, vaccines supplied in vials or syringes containing natural rubber should not be administered unless the benefit of vaccination clearly outweighs the risk of an allergic reaction to the vaccine. For latex allergies, other than anaphylactic allergies, vaccine supplies in the vials or syringes containing latex can be administered. Pregnancy. Inactivated influenza and tetanus, diphtheria, and pertussis vaccines are recommended during pregnancy. Live attenuated viral vaccines are contraindicated during pregnancy because of the theoretical risk of virus transmission to the fetus. Sexually active females who receive MMR2 or Varivax should be instructed to practice careful contraception for 1 month following receipt of either vaccine. On theoretical grounds, inactivated poliovirus vaccine should not be administered during pregnancy. However, it may be administered if the risk of exposure is imminent and immediate protection is needed. HPV vaccine should not be administered to pregnant women. There is no recommendation to administer HIV vaccine pneumococcal conjugate vaccine, or serogroup B meningococcal vaccine to a pregnant female, hepatitis A vaccine, hepatitis B vaccine, and meningococcal conjugate vaccine can be administered to a pregnant female in some circumstances. Data on the use of Hep B, C, PG, Men ACWY, TT, and the pneumococcal polysaccharide vaccines during pregnancies are limited. Immunosuppression. Live attenuated vaccines can cause severe or fatal reactions in immunosuppressed persons due to uncontrolled replication of the vaccine virus. Live vaccines should usually not be administered to severely immunocompromised or immunosuppressed persons with congenital immunodeficiency, leukemia, lymphoma, or generalized malignancy. However, persons with isolated B cell deficiency may receive the varicella vaccine. In general, the provider treating an immunosuppressed patient should determine the severity of that patient's immunosuppression. Certain drugs can also cause immunosuppression. For instance, persons receiving cancer treatment with alkylating agents, antimetabolites, or radiation therapy should not receive live vaccines. Live vaccines can be administered after chemotherapy or radiation therapy has been discontinued for at least 3 months. In addition, persons receiving large doses of corticosteroids should not receive live vaccines. This includes persons receiving 20 milligrams or more of prednisone daily, or 2 milligrams or more of prednisone per kilogram of body weight per day for 14 days or longer. The safety and efficacy of live attenuated vaccines administered concurrently with recombinant human immune mediators and immune modulators are not known. There is evidence that the use of therapeutic monoclonal antibodies, especially the anti-tumor necrosis factor agents such as adalimumab, infliximab, etanercept, golimumab, and certolizumab, PEGAL, all may lead to reactivation of latent tuberculosis infection and disease. These agents might also predispose a person to other opportunistic infections. Because these drugs vary dramatically in the scope and number of immune system targeted components, it is prudent to avoid administering live attenuated vaccines while patients are taking these medications. For vaccination against seasonal influenza, inactivated injectable alternatives are available. The time PCP should wait to administer a live virus vaccine after immune modulator drugs have been discontinued is not specific by the ACIP or other authoritative guidelines. No basis exists for interpreting laboratory studies of immune parameters with vaccine safety or efficacy. Lymphocyte-depleting agents such as alemtuzumab and rituximab may cause prolonged immunosuppression. Both inactivated and live vaccines should be withheld for at least 6 months following therapy with anti-B cell antibodies. Some experts recommend even longer than 6 months following anti-B cell antibodies. The optimal time for restarting immunosuppressive therapy after vaccination with live vaccines has not yet been studied, but the Infectious Disease Society of America recommends waiting at least 1 month. Consultation with the prescribing physician is recommended for the management of individual patients and guidance in estimating a patient's degree of immunosuppression. Inactivated vaccines cannot replicate, so they are safe to use in immunosuppressed persons. Certain vaccines are recommended or specifically encouraged because immunosuppression is a risk factor for complications from certain vaccine preventable diseases. However, Because of a relative functional immune system is required to develop an immune response to a vaccine, the immune response may be poor, depending on the degree of immunosuppression present. Human immunodeficiency virus infection. Persons who are infected with HIV may not manifest the disease, or they may be severely immunosuppressed. In general, the same vaccination recommendations apply to other types of immunosuppression. Live virus vaccines are usually contraindicated in those with severe immunosuppression, but inactivated vaccines may be administered if indicated. Flu mist should not be administered, but an age-appropriate inactivated or recombinant influenza vaccine should be administered. Hematopoietic cell transplant. Hematopoietic cell transplant, or HCT, results in immunosuppression due to ablative therapy administered before the transplant and therapies to prevent or treat graft versus host disease. In addition, HCT recipients are at increased risk for vaccine-preventable diseases because antibody titers decline 1 to 4 years after HCT if the recipient is not revaccinated. HCT recipients at increased risk should be routinely vaccinated after HCT against tetanus, poliovirus, MMR, streptococcal pneumoniae, and HIV, regardless of the source of the transplanted cells. MMR and varicella-containing vaccines should be administered 24 months after transplantation if the HCT recipient is presumed to be immunocompetent. Revaccination with inactivated vaccines, including influenza vaccine, should begin 6 months after HCT. However, the influenza vaccine may be administered as early as 4 months after HCT if needed. 3 doses of Prevnar 13 should be administered 3 to 6 months after HCT, followed by a dose of the PPSV23. A dose of MenACWY should also be administered 6 months after HCT. Invalid contraindications and precautions to vaccinate. Sometimes certain conditions or circumstances are inappropriately considered to be contraindications or precautions to vaccination. Such conditions or circumstances are known as invalid contraindications, and these misperceptions result in missed opportunities to administer needed vaccines. Some of the most common invalid contraindications are mild illnesses, pregnancy, breastfeeding, allergies that are not anaphylactic in nature, and certain aspects of patient family history. So, what is considered mild illness? Children with a mild acute illness, such as a low-grade fever, an upper respiratory infection, otitis media, or mild diarrhea, should be vaccinated on schedule. A low-grade fever is not a contraindication to vaccinate. Measuring temperature is not necessary before vaccination if the patient does not appear ill and does not report currently being ill. The ACIP has not defined a body temperature above which vaccines should not be administered. The decision to vaccinate should be based on the overall evaluation of the child rather than arbitrary body temperature. Non-anaphylactic allergy. If an allergy to a vaccine component is not severe, such as is not anaphylaxis, it is not a contraindication to that vaccine. Only a severe allergic reaction, anaphylaxis to a vaccine component, is a true contraindication to vaccinate. Allergy to products not present in vaccines. There are no contraindications or precautions for persons with nonspecific allergies, duck or feather allergies, or penicillin allergies, or for persons who have relatives with allergies or those taking allergy shots. Anyone with these allergies can and should be vaccinated. No vaccine available in the US contains duck antigen or penicillin. Antimicrobial therapy. Antimicrobials do not influence the immune response to most vaccines. However, antiviral drugs may affect vaccine replication in some circumstances. Flu mist should not be administered until 48 hours after the cessation of oseltamivir and zanamivir, 5 days after the cessation of peramivir, and 17 days after baloxavir. If possible, antiviral drugs that are active against herpes virus should be discontinued 24 hours prior to the administration of varicella-containing vaccines. Breastfeeding. Breastfeeding does not decrease the response to any routinely recommended childhood vaccines and is not a contraindication to vaccination. Breastfeeding also does not extend or improve the passive immunity to vaccine-preventable diseases that is provided by maternal antibodies. Household contacts of pregnant or immunosuppressed persons. Being a household contact of a pregnant person or immunosuppressed person is usually not a contraindication to vaccinate. It is critical that healthy household contacts of pregnant people and immunosuppressed people be vaccinated. Vaccination of healthy contacts reduces the chance that pregnant people and immunosuppressed people will be exposed to vaccine-preventable diseases. Most routinely recommended vaccines include live vaccines, such as MMR2, Verifax, Rotavirus, and Flumist, can be administered to a person who are household contacts of pregnant or immunosuppressed persons. If a varicella vaccine recipient has a rash or after vaccination, direct contact with susceptible household contacts with altered immunocompetence should be avoided until the rash has resolved. All members of the household should wash their hands after changing the diaper of an infant who received the RV. This minimizes rotavirus transmission, as shedding may occur up to 1 month after the last dose. Flu mist should not be administered to close contacts and caregivers of severely immunocompromised persons who require protective environments. Your preterm birth. Vaccines should be started on a schedule based on the child's chronologic age. Preterm infants have been shown to respond adequately to vaccines used in infancy. Studies demonstrate that decreased seroprotection rates might occur among infants with a low birth weight, so less than 2,000 grams, after the administration of the hepatitis B vaccine at birth. However, by the chronological age of 1 month, all preterm infants, regardless of initial birth weight or gestational age, are likely to respond as adequately as older and larger infants. Tuberculin skin test. Persons who need a tuberculin skin test can and should be vaccinated. All vaccines can be administered on the same day as a TST or at any time after the TST has been administered. For most vaccines, there is no TST timing restriction. An MMR-containing vaccine may decrease the response to a TST, potentially causing a false negative response in someone who has a tuberculosis infection. MMR2 can be administered the same day as a TST, but if the MMR2 has been administered and 1 or more days have elapsed, it is recommended in most situations to wait at least 4 weeks before administering a routine TST. There is no information available on the effects of varicella-containing vaccine or Flumist on a TST. Until such information is available, it is prudent to apply the same rules for spacing a measles-containing vaccine and TST to a varicella-containing vaccine and FluMist. In interferon gamma release assay, tuberculosis test may be affected by a live vaccine, so it is prudent to apply the same spacing rules as for TST and live vaccines. Screening for contraindications and precautions to vaccinate. The key to preventing serious adverse reactions for vaccination is effective screening. Every patient should be screened for contraindication and precaution before administering any vaccine dose. Effective screening can be accomplished by asking a few questions. Such questions would include: is the patient sick today? Does the patient have any allergies to medications, food, a vaccine component, or latex? Has the patient experienced any reaction after receiving a vaccine? Has the patient experienced a brain or other nervous system problem, including seizures? Does the patient have a long-term health problem with heart, lung, kidney, or metabolic diseases, asthma, a blood disorder, nose spleen, complement component deficiency, a cochlear implant, or a cerebrospinal fluid leak? Is the patient on any kind of long-term aspirin therapy? Does the patient have cancer, leukemia, HIV, AIDS, or any other immune system problems? Does the patient have a parent or sibling with an immune system problem? Has the patient taken medications that affect the immune system, such as prednisone, other steroids, or anti-cancer drugs, for the treatment of rheumatic arthritis, Crohn's disease, or psoriasis? Has the patient had radiation treatment? Has the patient received a transfusion of blood or blood products, immune globulin, or an antiviral drug in the past year? Is the person pregnant, or is there a chance the person could become pregnant during the next month? Has the patient received vaccination in the past 4 weeks? And finally, for infants, has the patient ever had intussusception? Intussusception is a contraindication for the RV. Adverse events following immunization and assessment of causality. An adverse event following immunization may or may not be related to the immunization. Further assessment is needed to determine if an adverse event is caused by a vaccine. A vaccine adverse reaction or side effect is an untoward effect caused by a vaccine. Adverse events following immunization can be classified by frequency, extent, severity, seriousness, causality, and preventability. Adverse events following immunization may be coincidental, or the vaccine may have increased the risk of an adverse event. Many adverse events following vaccination are coincidental. They are temporarily related to vaccination but occur by chance, without a causal relationship. To assess the causality of an adverse event following immunization, a great deal of information is generally needed. An adverse health event can be causally attributed to a vaccine more readily under the following condition. The health problem occurs during a plausible time period following vaccination. The adverse event corresponds to adverse events previously associated with the vaccine. The event is consistent with a specific clinical syndrome where the association with vaccination has strong biological plausibility, or where the syndrome is known to occur following the natural disease. A laboratory result confirms the association. The event recurs with readministration of the vaccine in the same patient. A controlled clinical trial or epidemiologic study shows a greater risk of a specific adverse event among vaccinated versus unvaccinated group. And lastly, the finding linking an adverse event to a vaccine has been confirmed by other studies. Importance of vaccine safety programs. Like any medical product, no vaccine is completely without risk. While most vaccines' adverse reactions are minor and self limited, some vaccines have been associated with extremely rare but serious health effects. The following key considerations underscore the need for an active and ongoing vaccine safety program. Decreases in disease risk. Most vaccine preventable diseases are at or near record lows. Many people no longer see reminders of the severity and potential life threatening complications of these diseases. Parents and providers in the United States may be more likely to know someone who has experienced an adverse event following vaccination than they are to know someone who has experienced a vaccine preventable disease. The success of vaccination has led to increased public attention on potential health risks associated with vaccines. Public confidence. Maintaining public confidence in vaccines is critical to prevent a decline in vaccination coverage that can result in outbreaks of disease. While most parents understand the benefits of vaccination and have their children vaccinated, some parents have concerns about the safety of vaccines. Despite high national vaccination coverage, there are local areas of low coverage that allow outbreaks of vaccine preventable diseases to occur, often the result of parents refusing or delaying their children's vaccinations because of concerns about vaccine safety. A higher standard of safety is generally expected of vaccines than of other medical interventions because, in contrast to most pharmaceutical products that are administered to ill persons for treatment purposes, vaccines are generally administered to healthy persons to prevent disease. Public tolerance for adverse reactions related to products given to healthy persons, especially healthy infants and children, is substantially less than for reactions to products administered to persons who are already sick. Less tolerance of risk associated with vaccines requires close monitoring and timely assessment of vaccine and adverse events to help distinguish true vaccine adverse reactions from coincidental unrelated events and to help maintain public confidence in vaccination. The federal government has several systems in place to ensure public confidence in vaccines. Vaccine Adverse Event Reporting Systems. The National Childhood Vaccine Injury Act of 1986 mandates that vaccine providers and vaccine manufacturers report certain adverse events following vaccination. This led to the creation of the Vaccine Adverse Events Reporting System in 1990. This system is a national spontaneous surveillance system, jointly administered by the CDC and the U.S. Food and Drug Administration. It receives about 30,000 reports per year, a seemingly large number, but relatively small, considering that millions of doses of vaccines are administered yearly to adults and children in the US. Vaccine providers are required by law to report any adverse event listed by the vaccine manufacturer as a contraindication to further doses of the vaccine. Any adverse event listed in the program table of reportable events following vaccination, which you can see at the website. Any adverse events that occur after the administration of a U.S. licensed vaccine, whether it is or is not clear if vaccine caused the adverse event, anytime during vaccine administration errors. Vaccine manufacturers are required to report all adverse events that come to their attention. This program collects information about the patient, the vaccine administered, the adverse event, and the person reporting the event. All reports are coded using the medical dictionary for regulatory activities. Terms are entered into the system's database. Attempts are made to obtain additional medical information for all reports, classified as a serious adverse event, including hospitalizations or prolongation of hospitalization. Life-threatening illnesses, permanent disability, congenital deformity, or even death. For these reports, letters to obtain information about recovery status are also sent to the person reporting the event. All patient identifying information submitted to this program, directly or as part of the follow-up activities, is protected by strict confidentiality requirements. The program has limitations inherent to spontaneous reporting system. Also, this program is not designed to determine if a vaccine's caused an adverse event, and additional studies are required to confirm possible safety signal detection by the program. Despite these limitations, the program has fulfilled its primary purpose of detecting new or rare vaccine adverse events, increases in rates of known adverse reactions, and patient risk factors for types of adverse reactions. In addition, the program often provides early safety data after a vaccine is licensed or during a public health emergency. Vaccine Safety Data Link. The CDC established that the Vaccine Safety Data Link, or VSD, to address gaps in the scientific knowledge of rare and serious adverse events following any kind of vaccination. This project involves partnership with large integrated health plans to monitor vaccine safety. Each participating plan uses its electronic health record and immunization information system to contribute to a large, linked database. These participating health events serve more than 10 million people annually, representing nearly 3% of the US population, and contains records for more than 180 million vaccinations, enabling the VSD to study possible rare adverse events. The VSD allows for planned immunization safety studies, as well as timely investigations of hypotheses arising from reviews of medical literature, reports to VAERS, changes in immunization schedules, or the introduction of new vaccines. Clinical Immunization Safety Assessment Project. The Clinical Immunization Safety Assessment, or CISA, project mission is to improve the understanding of adverse events following immunization at the individual patient level. The CISA project provides consultation to public health partners in the US and conducts high quality clinical research, including clinical trials across life stages, or the safety of influenza vaccines and the safety of vaccines in special populations. Post licensure rapid immunization safety monitoring system. The FDA's post-licensure rapid immunization safety monitoring system, or PRISM, uses a computer algorithm to conduct active vaccine safety surveillance, a cooperative effort between the FDA, Center for Biologic Evaluation and Research, and four healthcare and medical insurance organizations. PRISM analyzes health insurance claims data for potential vaccine safety signals. PRISM is also used to evaluate safety issues in targeted groups and to evaluate specific health conditions or outcomes. PRISM is part of the FDA's Sentinel Initiative, a national electronic system for medical product safety surveillance. Vaccine Injury Compensation Program. The main impact of the National Childhood Vaccine Injury Act was the creation of the Vaccine Injury Compensation Program. This program, administered by the Health Resources and Services Administration, provides financial compensation to persons who are found to have been injured by a vaccine covered by the program. The VICP provides liability protection for vaccine manufacturers and administrators. Compensation is provided to persons who experience certain vaccine adverse reactions on a no-fault basis. No-fault means persons filing claims are not required to prove negligence on the part of either the healthcare provider or manufacturer to receive compensation. The program covers most vaccines routinely given in the US. During the 2009 H1N1 influenza pandemic, the federal government implemented another compensation program, the Countermeasure Injury Compensation Program. This program provides compensation for certain persons who are seriously injured by countermeasures, as is specified in a declaration by the Secretary of the U.S. Department of Health and Human Services. Both bioterrorism and pandemic countermeasures are covered. Benefits and risk communication. Patients and parents should be informed of the benefits and risks of vaccines in understandable language. An opportunity for questions should be provided before each vaccination. Discussion of the benefits and risks of vaccination is sound medical practice and is required by law. The NCVIA legally requires vaccine information statements to be provided to the patient, parent, guardian, or legal representative by vaccine providers before each dose of vaccine. Documentation by the VIS was provided is also required. Copies of VISS are available from state and local immunization programs or can be downloaded. Translations of the VIS into languages other than English are available from some immunization programs and from immunize.org. Vaccine providers should anticipate questions parents or patients may have regarding the need for or safety of vaccination. Some people may refuse certain vaccines or even reject all vaccinations. Some people might have religious or personal objections to vaccination. It is essential that PCPs have a basic understanding of how patients view vaccine risk and develop effective approaches to deal with vaccine safety concerns when they arise. When a parent or patient initiates a discussion of a vaccine concern, the provider should discuss the specific concerns and use appropriate language to provide facts. Effective, empathic vaccine risk communication is essential in responding to misinformation and concerns. It is important to remind parents that state laws for school or childcare entry might require unvaccinated children to stay home from school during outbreaks. For patients who question or refuse vaccination, identifying common ground and discuss measures for deferring vaccination are more effective public health strategies than excluding these patients from practice. Documentation of VIS distribution is required, and they provide an outline for discussing vaccine benefits and their risks. Additional information about discussions should be documented in the patient's record, including the refusal to receive certain vaccines. Such documentation might reduce any potential liability if a vaccine preventable disease occurs in the unvaccinated patient. Managing adverse reactions after vaccination. PCPs should be familiar with identifying immediate type allergic reactions, including anaphylaxis, and be competent in treating these events at the time of vaccine administration. While severe allergic reactions to vaccines are rare, occurring at an appropriate rate of 1 to 2 for every 1 million doses of vaccine administered, all vaccine providers should have emergency procedures in place and be prepared to provide emergency care for a person who experiences an anaphylactic reaction. This includes the ability to administer epinephrine and certification in cardiopulmonary resuscitation. Equipment for maintaining an airway should be available for immediate use. All healthcare personnel should be familiar with their office emergency plan. Vaccine storage and handling. Vaccine providers are responsible for proper vaccine storage, handling, and administration. Timing and spacing of vaccine doses, observation of contraindications and precautions, and reporting of adverse events following vaccination to VAERS. Providers must discuss the vaccine benefits and risk and for management of vaccine adverse reactions with patients and parents. Vaccines need to be stored according to the manufacturer's recommendations, following CDC guidelines to prevent the loss of vaccines. The CDC provides the Vaccine Storage and Handling Toolkit to safely store vaccines. Vaccine cold chain. A cold chain is a temperature controlled supply chain that includes all vaccine related equipment and procedures. The cold chain begins with the cold storage unit at the manufacturing plant, extends to the transport and delivery of the vaccine, and proper storage at the provider facility, and ends with the administration of the vaccine to the patient. Manufacturers, distributors, public health staff, and healthcare providers share the responsibility to ensure that vaccine cold chain is maintained from the time vaccines are manufactured until they are administered. Vaccine storage and handling standard operating procedures. Facilities should develop and maintain clearly written, detailed, and up to date storage and handling standard operating procedures. SOPs should be reviewed by all staff and updated by the vaccine coordinator annually. General information include contact info for vaccine manufacturers, equipment service providers, and important facility staff, as well as job descriptions, regularly used forms, and staff training requirements. Routine storage and handling, including information for all aspects of vaccine inventory management, from ordering to monitoring expiration dates and storage conditions. And finally, emergency vaccine storage, handling, and transport outline steps to be taken in the event of equipment malfunction, power failures, natural disasters, or other emergencies that might compromise vaccine storage conditions. Vaccine administration. Vaccine administration is a key factor in ensuring vaccination is as safe and effective as possible. Administration involves a series of actions: assessing patient vaccination status and determining needed vaccines, screening for contraindications and precautions, educating patients, preparing and administering vaccines properly, and documenting the vaccine administered. Professional standards for medication administration, manufacturer instructions, and organizational policies and procedures should always be followed. Assess for needed vaccines. The patient's immunization status should be reviewed at every healthcare visit. Using the patient's immunization history, PCPs should assess for all routinely recommended vaccines as well as any vaccines that are indicated based on existing medical conditions, occupation, or other risk factors. To obtain a patient's immunization history, information from immunization information systems, current and historical medical records, and personal shot record cards may be used. In most cases, PCPs should only accept written, dated records as evidence of vaccination. However, self-reported doses of influenza vaccines or the PPSV23 are acceptable. Missed opportunities to vaccinate should be avoided. If documented immunization history is not available, administer the vaccine that are indicated based on the patient's age, medical condition, and other risk factors, such as planned travel. Screen for contraindications and precautions. Before administering any vaccine, patients should be screened for contraindications and precautions, even if the patient has previously received that vaccine. The patient's health condition or recommendations regarding contraindications and precautions for vaccination may change from one visit to the next. To assess patients correctly and consistently, PCPs should use a standardized, comprehensive screening tool. To save time, some facilities ask patients to answer screening questions before seeing the provider, either electronically via an online healthcare portal or on a paper form while in the waiting room or exam room. Immunize.org is an excellent source for screening tools for children, adolescents, and adults. Educate patients and or parents about needed vaccines. Vaccines are one of the safest and most effective ways to prevent disease. All healthcare personnel, including non-clinical staff, play an important role in promoting vaccination and creating a culture of immunization within the clinical practice. Inconsistent messages from healthcare personnel about the need for and safety of vaccines may cause confusion about the importance of vaccines. Studies show healthcare providers are not the most trusted source of vaccine information. Research also shows when a strong recommendation is given by healthcare providers, a patient is 4 to 5 times more likely to be vaccinated. When providers use presumptive language to initiate vaccine discussion, significantly more parents choose to vaccinate their children, especially at first time visits. Instead of asking, What do you want to do about shots today? An approach using presumptive language would be to state your child needs 3 vaccines today. Some patients and parents may have questions or concerns about vaccination. This does not necessarily mean that they will not accept vaccines. Sometimes they simply want to hear their provider's answers to their questions. This, to me, personally sounds like they want you to push vaccines. Aftercare instructions. Patient and parent education should also include a discussion of comfort and care strategies after vaccination. Aftercare instructions should include information for dealing with common side effects such as injection site pain, fever, and fuzziness, especially in infants, such as a cold compress. Instructions should also provide information about when to seek medical attention and when to notify the healthcare provider about concerns that arise following vaccination. Aftercare information can be given to patients or parents before vaccines are administered, leaving the parent free to comfort the child immediately after the injection. Pain relievers can be used to treat fevers and injection site pain that might occur after vaccination. In children and adolescents, a non-aspirin containing pain reliever should be used. Aspirin is not recommended for children and adolescents. Immunize.org has excellent after the shot patient-parent handouts. And here is a picture of talking with parents about vaccines for infants. And as it looks, it is always the parents' consent with no further questions. Administer the recommended vaccine dose. If the parents are not ready to vaccinate, give your strong recommendation and then, when the parent accepts your recommendation, administer the dose. If the patients have specific questions or concerns, listen to and respond to the questions. Parents respond positively to your answers, then go ahead and just administer the vaccine. That is the impression that they push. Vaccinate, vaccinate, vaccinate. Vaccine administration safety. Occupational Safety and Health Administration, or OSHA, regulation have not typically required gloves to be worn when administering vaccines, unless the person administering the vaccine is likely to come in contact with potential infectious body fluids or has open lesions on the hand. In the setting of the COVID-19 pandemic, gloves should be worn when administering intranasal or oral vaccines. If gloves are worn, they should be changed and hand hygiene should be performed between patients. Several critical factors are indicated for vaccine preparation and administration. All indicators must be carefully followed to ensure safe and appropriate immunization. These include ensure that the vaccine and diluent are correct. Once reconstituted, the vaccine should be administered within the time frame specified for the manufacturer's packaging insert. Otherwise, the vaccine needs to be discarded. Confirm the expiration date has not passed. Inspect the vaccine. Vaccines should be drawn just before administration. In general, administer the oral vaccine before injectables. Most vaccines are available in single-dose vials. Manufactured filled syringes are prepared with a single dose of vaccine and sealed under sterile conditions by the manufacturer. Multi-dose vials contain more than one dose of vaccine. An oral applicator is for use with oral vaccines and contains only one dose of medication. Intranasal sprayer is used for the LAIV. A separate needle and a syringe must be used for each vaccine administered. In some instances, a vaccine must be used by a date earlier than the expiration date on the label. If multiple vaccines are administered at a single visit, administer each preparation at a different anatomical site. Follow age-appropriate positioning best practices. And lastly, provide the parent and guardian with a copy of the updated shot record at each visit. Needle length and injection sites for various ages for intramuscular injections. Your newborn gets a 5/8 to 1 inch needle, and that in the vastus lateralis. For the 1 to 36 month, 1 inch needle in the vastus lateralis. 36 months to 6 years, 1 inch into the deltoid. The vastus lateralis is a preferred site to decrease redness and swelling. 3 to 10 years, 1 inch needle into the deltoid. 11 to 21, 1 inch needle into the deltoid. If the vastus lateralis, however, is used, a 1.5 inch needle may be needed. Needle lengths and injection sites for various ages for subcutaneous injections. In that case, the anterolateral thigh is recommended for subcutaneous vaccines for infants until at least age 12 months. The deltoid 5/8 inch needle is recommended for all ages 12 months and older, using a 45-degree angle. Pain relief for vaccines. Vaccinations are the most common source of procedural pain for healthy children and can be a stressful experience for persons of any age. It has been estimated that up to 25% of adults have a fear of needles, with most needle fears developing during childhood. If not addressed, these fears can have lifelong term effects, such as a pre-procedural anxiety and avoidance of needed healthcare throughout a person's lifetime. Fear of injections and needle stick pain are often cited as a reason why children and adults refuse vaccines. Several techniques can be employed to decrease injection pain. Breastfeed children 2 years of age and younger while vaccines are administered. Give a sweet-tasting fluid such as sucrose to children who are not breastfed. Offer topical analgesics and pain relievers. These medications must be applied either before the child leaves home or while the child is waiting in the waiting room. Inject vaccines quickly and administer vaccines that cause the most pain last, such as HPV and MMR. Forms of distraction such as blowing bubbles or watching videos may also be employed. Managing acute reactions after vaccination. Severe life-threatening anaphylactic reactions follow vaccinations are rare. Potential life-threatening adverse reactions that can occur immediately after vaccination are severe allergic reactions and syncope. Symptoms of immediate type allergic reactions can include local or generalized urticaria, angioedema, respiratory compromise due to wheezing or swelling of the throat, hypotension, and shock. All vaccine providers should be certified in CPR and be skilled in administering epinephrine. Equipment needed for maintaining an airway should be available for immediate use, and the provider should be skilled in using the equipment. All PCPs who administer vaccines to older children, adolescents, and adults should be aware of the potential for syncope after vaccination and the related risk of injury caused by falls. Appropriate measures should be taken to prevent injuries if a patient becomes weak or dizzy or loses consciousness. Have the patient seated or lying down for vaccination. Be aware of symptoms that precede fainting. Provide supportive care and take appropriate measures to prevent injuries if such symptoms occur. Strongly consider observing patients for 15 minutes after vaccination to decrease the risk of injury should they faint. Documenting immunizations. Accurate and timely documentation can help prevent administration errors and curtail the number of cost of excess vaccine doses. Date of administration, vaccine manufacturer, vaccine lot number, name and title of the person who administered the vaccine, the address of the facility where the permanent record will reside, edition date of the VIS distributed, and the date it was provided to the patient, and the route, dosage, and site all must be documented in the patient's permanent record. Any adverse events after vaccination and any serologic test results related to vaccine preventable disease must always be noted. It is also important to document when parents refuse vaccines despite the vaccine provider's recommendation. Inactivated vaccines. DTaP vaccines for ages 6 weeks to 6 years. The only effective prevention of DTaP is vaccination, and the vaccines are inactivated. DTaP vaccine is indicated for children ages 6 weeks to 6 years. The routine schedule is a primary series of 3 doses at ages 2, 4, and 6 months. A booster dose between ages 15 through 18 months and another dose between ages 4 through 6. So a total of 5 doses. See the footnotes on the current ACIP schedule for full dosing and spacing instructions. Infanrix and Daptocel are the single antigen brand names, and although there is a preference for using the same brand for all 5 doses, interchanging is acceptable. If a child has a valid contraindication to the pertussis vaccine, DT should be used to complete the vaccine series. Several tetanus, diphtheria, and pertussis containing combination vaccines are available for children 6 weeks to 6 years. Refer to the current ACIP vaccine schedule footnotes for DTaP for use of these combination vaccines. Pediatrics, Pentacel, Daptocel, Quadracel, Vaccilis, and Kinrix. Precautions for any pertussis-containing vaccines include a fever of 40.5 or higher within 48 hours containing inconsolable crying lasting more than 3 hours within that 48-hour period. Pale or limp episodes or collapse within 48 hours, or a seizure within 3 days of the dose. Delay administration until moderate to severe febrile illness has resolved. Pertussis-containing vaccine should be deferred for children with a progressive neurologic problem until the condition is stable. Contraindications for any pertussis-containing vaccine are previous encephalopathy within 7 days after DTaP and or progressive neurologic disorders. All DTP vaccines are administered as IM injections. Diphtheria, tetanus, pertussis vaccines for ages 7 years through adulthood. So, DTaP vaccines are approved for booster doses for persons who have completed the recommended childhood DTP or DTaP vaccine series. A Tdap dose for tetanus prophylaxis is indicated for wound management if at least 5 years have elapsed since the last dose of tetanus-containing vaccine. Both Tdap vaccines are approved for use in persons 7 years or older. A single DTaP dose is recommended for adolescents 11 through 18 years of age who have completed the recommended childhood vaccine series, preferably at ages 11 through 12. Individuals who do not have documentation of at least 3 doses of DTaP should receive a series of 3 doses of tetanus and diphtheria containing vaccine. One of these doses, preferably the first, should be the Tdap. The remaining 2 doses should either be TD or Tdap. To reduce the burden of pertussis in infants, the dose of Tdap has been recommended during each pregnancy since 2012, although this practice is an off-label use. For persons 7 to 9 years of age who receive the dose of Tdap as part of their catch-up series, an adolescent Tdap dose should be administered at 11 through 12 years of age. If the Tdap dose is administered at age 10 years or older, the Tdap dose may count as the adolescent Tdap dose. TD brand names are Tenavac and TDvax, and they can be used interchangeably. After receiving the Tdap, persons should continue to receive a dose of TD or Tdap for routine booster immunization against tetanus and diphtheria, with a preference for Tdap. GBS occurring 6 weeks or less after a previous dose of tetanus toxide containing vaccine is a precaution for tetanus toxide containing vaccines. Any DTaP or Tdap vaccine can cause redness or swelling at the site or fever. These symptoms can be managed with cool compression and Tylenol. Arthur reactions, whole limb swelling, can also occur following immunization, but are not common and are not allergic reactions. Polio vaccine. The only effective prevention for poliomyelitis is vaccination. The United States has been polio-free since 1979. In 1999, the ACIP recommended an all-inactivated polio vaccine schedule to eliminate the risk of vaccine-preventable polio. The first dose of IPV vaccine can be administered as early as age 6 weeks, but is usually administered at 2 months, with a second dose at 4 months. The third dose should be given at ages 6 through 18 months of age. The recommended interval between the doses is the primary series is 2 months. However, if accelerated protection is needed, the minimum interval between each of the first 3 doses of IPV vaccine is 4 weeks. The final dose in the IPV series should be administered at age 4 through 6 years and at least 6 months after the previous dose. A dose of IPV vaccine on or after age 4 years is recommended. IPV is contraindicated if there is an allergy to any component of the vaccine, which can include neomycin, streptomycin, polymyxin B, and is very rare. The polio vaccine is administered either subcutaneous or intramuscular. The precaution is a moderate or severe illness. Haemophilus influenza vaccine. HIV disease was the leading cause of meningitis in children under 5 years of age until the introduction of the vaccine. The only prevention is vaccination. The vaccine is inactivated with a number of doses dependent on the brand administered, and the HIV component is contained in some combination vaccines. HIV vaccine is not given to children 5 years or older. 3 monovalent HIV polysaccharide protein conjugate vaccines are currently licensed for the use in the United States. Pentacel and Vaxilis are HIV-containing combination vaccines. Consult the current ACIV schedule for dosing schedules and indications. The contraindication includes an allergic reaction to any component of the vaccine and is very rare. Precautions include a moderate or severe acute illness. Hepatitis B vaccine. Hepatitis B is the leading cause of cirrhosis, liver cancer, and death. Before the introduction of the vaccine, the only prevention was hand washing, avoidance of blood and body fluids, and immune globulin. Hepatitis B vaccination is recommended for all medically stable infants weighing at least 2,000 grams within 24 hours of birth. Only a single component vaccine should be used for the birth dose, and doses administered before age 6 weeks. Single component vaccines are Engerix B and Recombavax HB. The usual schedule is 0, 1 through 2, and 6 through 18 months. The hepatitis B vaccine is inactivated and given IM. The final dose should be administered no earlier than the 6-month birthday. Hepatitis B is included in Pediatrics and Vaxilis. See the ACIP schedule for use and indications for the combination vaccines. If the mother is hepatitis B positive, the neonate must receive Hep B vaccines within 12 hours of life and hepatitis B immune globulin. The second dose is given at age 1 to 2 months, and the third dose completes the series at age 6 months, with serology testing at age 9 months. The hepatitis B vaccine is a component in the combination vaccines Pediatrics and Vaxilis. Again, see the ACIP immunization schedule for indications and schedules for these vaccines. All children and adolescents who did not receive the hepatitis B vaccine as infants should receive the vaccine following the 0, 1, and 6-month schedule. Recombivaks and Engerix-B are single antigens. The contraindication is an allergy to the vaccine, which is very rare. A moderate or severe illness is, however, a precaution. The hepatitis A vaccine. In the pre-vaccine era, the primary method used for preventing hepatitis A was again hand washing and passive protection with immune globulin. Before 2004, hepatitis A was the most frequently reported type of hepatitis in the US. Single antigen Hep A vaccines are available in pediatric and adult formulation and is an inactivated vaccine. Hep A, Hep B. Twinrix is licensed for persons 18 years of age or older and administered as a 3-dose series at 0, 1, and 6 months. Routine Hep A vaccine is given at 12 months and 18 months of age, or 2 doses, 6 months apart for all other age groups, as catch-up. If children are traveling to high-risk areas, the vaccine can be administered at 6 months of age or older. Revaccination would then be required once the child was 12 months of age, with 2 doses separated by 6 months. The contraindication is an allergy to the vaccine, which again is very rare. The precaution is moderate or severe illness. Pneumococcal vaccines. With the decline of invasive HIV disease, as pneumoniae has become the leading cause of bacterial meningitis among children younger than age 5 in the US. All children 2 through 59 months of age should routinely receive a 3-dose primary series of PCV13 at age 2, 4, and 6 months, and the dose 4 booster at 12 through 15 months. It is an inactivated conjugated vaccine. Unvaccinated children 7 months or older do not require a full series of 4 doses. The number of doses depend on the child's current age and the age at which the first dose of PCV13 was administered. See the footnotes on the current ACIP schedule for the appropriate number of doses and spacing. Children 2 years of age or older with certain conditions should receive both PCV13 and PPSV23 or PPSV23 alone. PPSV23 is not recommended for children younger than 2 years. Children who have a condition for which PCV13 is indicated should receive the PCV13 first, followed by the PPSV23 at least 8 weeks later. The recent licensed PCV15 may be used as an option to PCV13 for children aged 19 years according to the current recommended PCV13 dosing and schedule, that is 19 years and younger. The contraindication is severe allergic reaction to a vaccine component or following a prior dose, which is very rare. The precaution is moderate to severe illness. Local reaction of redness and swelling are common and can be managed with a cool compress. So, conditions with pneumococcal polysaccharide vaccine 23 valent. All its indications are listed here in the following table. Please hit pause to read through them. Which brings us to the human papillomavirus vaccine, or HPV, which is the most common sexually transmitted infection in the United States. Although the majority of HPV infections are asymptomatic and resolve spontaneously, persistent infection can develop into anogenital warts, precancers, and cervical, anogenital, or oropharyngeal cancers in both women and men. HPV vaccine prevents the 2 most common strains, HPV type 16 and 18, in addition to 5 additional high-risk types and type 6 and 11, which may cause warts. HPV vaccine should be initiated at age 9 to 11 years with a catch-up for all older adolescents and young adults through 26 years of age. Younger age children have the most robust immune response. The schedule for ages 9 to 14 at initiation is a 2-dose series at 0 and 6 months. If the vaccine is started at age 15 and older at initiation, the schedule is a 3-dose series at 0, 1, and 2 months and 6 months. Immune-compromised individuals should receive the 3-dose series. The contraindication is a severe allergic reaction to a vaccine component, or following a prior dose, or history of immediate hypersensitivity to yeast. Pregnant people should not receive the vaccine, but there have been no documented birth defects related to accidental administration. Moderate or severe illness is a precaution. Local reactions of redness and swelling are common and may be managed with cool compresses. Which brings us to the meningococcal vaccine. Serogroups B and C are the major causes of meningococcal disease in the US, each being responsible for approximately 25 to 40% of cases. Serogroups W and Y, along with non-groupable meningococcal, are responsible for another 5 to 15%. The proportion of cases caused by which serogroup varies by age group. Roughly 60% of disease among children and young adults under 24 years of age is caused by serogroup B. In particular, among individuals 18 to 24 years of age, college students have more than 3 times the risk of serogroup B meningococcal disease as similarly aged individuals. Before vaccination, there was no effective prevention. 3 quadrivalent meningococcal conjugate vaccines were licensed for the use of in the United States. The MEN ACWY-D, MEN ACWCRM, and MEN ACWY-TT. Menactra is approved for use in persons ages 9 months through 55 years. Menveo is approved for the use in persons of aged 2 months through 55 years, and Menquadfi is approved for use in persons ages 2 years or older. All are administered IM. Routine dosing is at 11 years of age with a booster shot at 16. See the current ACIP schedule for specific recommendations for each brand of vaccine and for indicated high-risk conditions. Contraindication is a severe allergic reaction to the vaccine or to any component. The precaution is a moderate to severe illness. Redness and swelling can follow immunization and can be managed with cool compresses and Tylenol. 2 recombinant serogroup B meningococcal vaccines are licensed for the use within the United States. The MenB FHBP and MenB4C. See the current ACIP schedule for high-risk conditions. These vaccines are not interchangeable, and a series must be restarted if the brand of vaccine used for the previous dose is not available. Adolescents 16 through 23 years of age can receive the MenB vaccine for short-term protection against most strains of serogroup B meningococcal disease based on shared clinical decision-making. The preferred age for vaccination is 16 through 18 years of age. The vaccines are contraindicated if there has been a severe allergic reaction to either the vaccine or a component of such reactions are very rare. See the footnotes on the current ACIP schedule for details. Moderate or severe acute illness are precautions, along with latex sensitivity. Leading us to the dengue vaccine. Dengue is common in the U.S. territories of American Samoa, Puerto Rico, and the U.S. Virgin Islands, and the freely associated states, including the Federated States of Micronesia, the Republic of Marshall Islands, and the Republic of Palau. For this reason, the ACIP has added the dengue vaccine to the ACIP annual schedule. Contraindications include children under 9 years of age, since these children are less likely to have had a prior dengue infection. People over 16 years of age, because there are not enough data to show how well the vaccine works in the population. Children who have not had a prior dengue infection, children with weakened immune systems, children who have had a severe allergic reaction to a previous dose of the vaccine, and children who have had severe allergy to any ingredient in the vaccine. Travelers and non-residents of areas where dengue is common, since the FDA has not approved dengue vaccine for use in travelers. Dengue vaccine is administered subcutaneously at 0, 6, and 12 months. The most common side effects are soreness, itchiness, or pain at the injection site, headaches, lack of energy, and general discomfort. Syncope is a precaution, since recent data suggests that adolescents are more likely to experience syncope following vaccination. Influenza vaccines, which are inactivated and live vaccines. Influenza vaccines composition is reviewed and updated annually each year, since the influenza virus is constantly changing. Considerations include the influenza viruses are causing illness, the extent to which viruses are spreading, and how well the previous season's vaccine protects against those viruses. Three types of influenza vaccines are available in the US. Inactivated influenza vaccine, which is IIV, the LAIV, and the RIV. The trivalent vaccine contains three inactivated viruses, which include type A H1N1, type A H3N2, and type B. Quadrivalent influenza vaccines were first introduced during the 2013 to 2014 season. They contain the same antigens as trivalent vaccines, with an additional type B strain. Influenza vaccination is recommended annually for persons 6 months of age and older who do not have contraindications. Vaccination is particularly important for persons at increased risk for severe illness and complications from influenza. All influenza vaccines, with the exception of LAIV, are administered IM. LAIV is administered via the intranasal route. Persons 9 years of age or older should receive one dose of a licensed age group appropriate vaccine each influenza season. Children 6 months through 8 years of age who do not have documentation showing receipt of 2 or more doses of any influenza vaccine before July 1st should receive 2 doses of a licensed age appropriate vaccine. The purpose of the initial 2-dose series is to prime the immune system in vaccine-naive infants. This 2-dose series should be administered at least 4 weeks apart. The contraindication to any formulation of influenza vaccine is severe allergy, followed by previous dose. Moderate or severe acute illness and a history of GBS within 6 weeks of receipt of the influenza vaccine are the precautions. See the footnotes for the influenza vaccine on the current ACIP immunization schedule. Local reactions of redness and swelling are common and may be managed with a cool compress. Live attenuated vaccines, which would be our rotavirus vaccine. In the pre-vaccine era, the majority of children were infected by 5 years of age. The rotavirus was responsible for up to 500,000 deaths among children annually worldwide. The RV is a live oral vaccine. It is routinely recommended for infants. ACIP developed age recommendations that vary from those of the manufacturer. The vaccine should be administered orally as a series of either 2 doses for the RV1 vaccine or 3 doses at age 2, 4, and 6 months for the RV5 vaccine. The vaccination series for both vaccines may be started as early as age 6 weeks. This is an off-label recommendation for both vaccines because the label maximum age for the RV1 vaccine is 24 weeks, and the labeled maximum age for the RV5 vaccine is 32 weeks. Do not start the series on or after 15 weeks, 0 days. The maximum age for the final dose is 8 months, 0 days. If any dose in the series was RV5 vaccine, or the vaccine brand used for any prior dose in the series is not known, a total of 3 doses RV should be administered. Contraindications include hypersensitivity, allergic reactions, severe combined immunodeficiency syndrome, history of intussusception, and latex allergy. Spina bifida or bladder extrophy are precautions for Rotarix, but not for Rototec vaccine. Additional precautions are moderate or severe acute illness, including gastroenteritis and altered immunocompetence. Limited data do not indicate a different safety profile in HIV infected versus HIV uninfected infants, or with chronic gastrointestinal disease. Which brings us to measles, mumps, and rubella vaccine. Before a vaccine was available, infection with the measles virus was nearly universal during childhood, and more than 90% of persons were immune due to past infection by age 15. Measles is still a common and often fatal disease in developing countries. In the United States, there have been a recent outbreak, the largest occurring in 2019, primarily among people who were not vaccinated. A successful mumps vaccination program in the US led to a greater than 99% reduction in the number of mumps cases reported annually. However, starting in 2006, there has been an increase in mumps cases and outbreaks, particularly in close contact settings, with many occurring among fully vaccinated persons. Mumps is a weaker vaccine, and when a case of mumps enters the community, the risk of vaccine breakthrough rises. Rubella used to be the worldwide infection. Due to the vaccine, endemic rubella and congenital rubella syndrome were eliminated in the US in 2004 and in the region of the Americas by 2009. The MMR vaccine is a live attenuated vaccine and is administered via the SC route. All 3 antigens are contained in the same vaccine presentation in the US. There is no single antigen for any of these antigens. A new MMR vaccine, Priorix, was recently licensed, and ACIP has determined that it is generically equivalent to the current brand of MMR2 and is interchangeable. MMR is the 2-dose series administered at ages 12 months and 4 years. MMR can be given at ages 6 months for children who are traveling to endemic areas. These children then need to repeat the dose on or after age 12 months and complete the series at age 4 years. Refer to the current ACIP schedule for information on catch-up schedules. Proquad MMRV can be administered when both MMR and VAR are indicated. The CDC expresses a preference for the separate MMR and VAR for infants because of the increased risk of fever and the potential for accompanying febrile seizures. Adverse reactions include fever, rash, seizure due to fever, encephalopathies, thrombocytopenias, arthralgias, and very rare anaphylaxis. The most common are fever and rash, while adolescents and adults are more likely to develop arthralgias. Contraindications are severe allergic reaction to a vaccine component or following a prior dose. Severe immunocompromised systemic high-dose corticosteroid therapy for 14 days or more. HIV infection regardless of immunocompetence status. Family history of congenital or hereditary immunodeficiency in first-degree relatives, and pregnancy. Precautions include moderate or severe acute illness, alpha-gal allergy, receipt of antibody-containing blood products, history of thrombocytopenia purpura or thrombocytopenia, need for TST or interferon gamma release assay testing. MMR2 vaccine should be administered to persons who are not severely immunocompromised. Please see the current CDC schedule footnotes for specific information regarding CD4 counts under special conditions. Simultaneously, use of aspirin or aspirin-containing products, personal or family history of seizures of any etiology, and the receipt of a specific antiviral drug 24 hours before vaccination are precautions only for the MMRV. Varicella vaccines. The incidence of varicella as well as varicella-related hospitalizations has decreased significantly since the implementation of the National Varicella Vaccination Program in 1995. Varicella infections are generally not life-threatening, and the clinical course in healthy children is generally mild, with a fever of 102 and other systemic symptoms such as malaise and headaches. The infection usually resolves within 2 to 4 days after the onset of the rash. The symptoms are nonetheless very uncomfortable for those affected, and severe complications can occur. Varicella is no longer a rite of passage for children thanks to the vaccine. VAR, or Varivax, is a live virus vaccine and is administered as a two-dose series at ages 12 to 15 months and 4 years and administered subcutaneously. See the current ACIP schedule footnotes for catch-up and scheduling information. Adverse reactions can include fever, rashes, seizures due to fever, encephalopathy, and thrombocytopenia. Contraindications are high dose, long term corticosteroids, chemotherapy, severe allergic reactions to a vaccine component, or following a prior dose, immunosuppression due to leukemia, lymphoma, generalized malignancy, immune deficiency disease, or immunosuppressive therapy, family history of congenital or hereditary immunodeficiency in first degree relatives. HCT, pregnancy, and HIV infection. Which brings us to our last vaccine, the mRNA vaccines, COVID 19. The COVID 19 pandemic has caused the loss of over 1 million American lives. Since the advent of the COVID 19 vaccine, case counts have drastically reduced infections in the U.S. COVID 19 vaccines for children and adolescents are mRNA vaccines that are designed to provoke the body to remember the antigen and mount an immune response to the spike protein when it is encountered. While the vaccine may be new, the technology has been available for over 10 years. COVID-19 vaccine by Pfizer and BioNTech are now recommended for all children, beginning at 6 months of age under the emergency use authorization and are administered IM. The doses vary in both vaccines for the age of children. Consult the CDC immunization website for the latest updates regarding dosage and administration of the vaccine. Vaccine side effects include pain, redness, and swelling at the injection site. Additional side effects may include tiredness, headache, muscle pain, and chills, fever, and nausea. Children 3 years and younger can also experience enlarged lymph nodes, irritability, crying, sleepiness, and loss of appetite. Contraindications are a history of severe allergic reactions after a previous dose or to the components of COVID-19 vaccine, and a history of a known diagnosed allergy to the component of COVID-19 vaccine. Rare cases of myocarditis or pericarditis have been identified as side effects following mRNA COVID-19 vaccines. This reaction has occurred most frequently in adolescent and young adult males within the first week after receiving the second dose of an mRNA COVID-19 vaccine. Additional resources, as always, include the ACIP schedule, the CDC, the CDC's vaccine schedule, the Children's Hospital of Philadelphia Vaccine Education Center, Families Fighting Flu, Immunize.org, the National Adult Immunization Summit, and the National Network of Immunization Coalition. Nurses Who Vaccinate, Vaccinate Your Family, and finally, Voices for Vaccines. We'll also take a brief look through all of the resources and sources, and that should conclude our chapter for today. As always, I thank you for listening, and I'll see you at the next chapter. Take care, and goodbye.